I was disabled, able to talk. So today, moderating for you, my name is Pamela Were from International Cancer Institute. I'll be taking you through I'll be moderating through these lung cancer presentations, and we are going to have 4 presenters. I take this opportunity to welcome all of you to this session. We will have presentation from Kennedy Olweny, who is a clinician at the International Cancer Institute. We'll also have a presentation from Karen Kasera, who is also an oncology nurse and wound care nurse from Homa Bay Teaching and Referral Hospital. We'll also have Florence Nyambura, who is a lung cancer survivor, and myself, Pamela, moderating. So I take this opportunity to welcome all of you. And at this juncture, I would also want to thank Kenko for giving us this opportunity. I know we are muted, but just in case you are not muted, make sure that your speaker is on mute so that we don't interrupt any proceedings. And welcome. So I take this opportunity to welcome Ken Olweny. Ken Olweny is a clinician at the International Cancer Institute. He's going to do a presentation on clinical presentation, diagnosis, treatment, and general management of lung cancer. I believe Ken will be able to share his screen, and I welcome you, Ken. Can you kindly take over? Karibu.
So thank you, everyone, and thank you, Pamela. And allow me to share my screen. Hope everybody is able to see my screen.
Yes, we are able to see the screen, and
just allow me to put it in a slide show. Sorry. So thank you very much, everyone, for this opportunity, and allow me to go straight away the presentation. So my slide is not moving from my end.
Sorry? Then do you have any challenge?
Yes, my slide is not moving easily from my side.
Okay.
Yes.
And I'm also not able to but I can see they're moving now.
Yes.
Yeah.
Yes.
Okay,
thank you very much. So for today, you will allow me to go through the following outline. We want to look at what lung cancer is. Then we are also going to see the opportunity of seeing the causes and risks for lung cancer. Then we also want to tackle types of lung cancer. Then the clinical presentations, the diagnosis for lung cancer, the staging of lung cancer, treatment of lung cancer. Then generally we want to look at the management of lung cancer. So what is lung cancer? So for us, what do we define as a cancer? So if we talk about cancer, we are looking at the body cells which are uncontrolled, that will normally crowd out other normal cells and then end up having abnormal functions. So if you look at the lung cancer, it may begin from the lung, then metastasize to other body cells, or you may get cancer from other organs metastasizing or spreading to the lungs. So the end results, you'll find that it affects the correct functioning of the body organ. So just to remind ourselves about the anatomy of the lung, this is the lung. On the right side, we normally have the 3 lobes, and then on the left side, we have the 2 lobes. So the lungs normally have a total of around 5 lobes, comparing the 2 sides. So this is what we use to that will help us to exchange oxygen from the body organs and to the external. And it is a very important organ for us. And if we have changes in terms of cells growing haphazardly out of control, then we end up having lung cancer. If we talk of lung cancer, we look at how common is this lung cancer. So in terms of GlobalCan 2020, we look at lung cancer. It was presenting at 11.4%, which is a bit quite high globally. And again, if you look at the mortality rate, both for male and female, we find that lung cancer is high, rating number 2, after all other cancers combined, apart from the colorectal, the liver, the stomach, breast, esophagus, and prostate cancer. So it is a global concern, and that's why we really need to talk about that. So how is this in Kenya? In Kenya, not that much in terms as compared to other cancers, ranging from breast, cervical, prostate, and esophagus. But why do we get concerned about what I've just presented? And I'm talking specifically now for the breast cancer. Initially, I've just said that lung cancer we may get lung cancer as a result of metastasis from other sites. For example, if you look at breast cancers, majority in the male population, you'll get that we have a lot of metastasis, and this goes to the lungs. So as we look in a bigger picture in terms of cancers, and in terms of breast cancer, we really need to do something in terms of early diagnosis. Because if you don't do much about early diagnosis for breast cancer in both populations, then the site for metastasis actually is going to the lungs. And this will also now increase the statistics and also increase the need that will be needed to tackle the lung cancer. So in Kenya, still looking at the data, globally, lung cancer is ranked number 14. And as you look at other cancers, that's how it is presenting. And again, breast becomes number 1. And as I've earlier alluded, we really need to do something in terms of early diagnosis for breast cancer. If we don't work on that, then the lung cancer will move from number 14 and even be a major concern for us. So if we look at now the risk factors for cancer, number 1, almost 90%, we are talking about smoking. And smoking normally account for approximately 90% of all the cancers, apart from the 10%, which we may allude in terms of the genetic makeup. Then if you also look at the associated risk factors for lung cancer and smoking, we are targeting the number of cigarettes somebody can be smoking per day, looking at the lifetime duration of smoking, at which age did they start, the degree of inhalation of the smokes, and this includes the tar, the nicotine, and the cigarette. Both unfiltered cigarettes, this really accounts for a lot of contamination. So in terms of prevention, just talking a bit about that, that if we cease from smoking, then we are decreasing the risk of contracting lung cancer for up to 20 to 90%. So for a population of adults who normally quit smoking 6 to 10 years of their life, the expectancy now will depend on the age when they quit the smoking. So we advocate for smoking reduction that may make us to be at risk of getting lung cancer. So we don't only talk about those who are smoking directly, but we have also a population who do secondary smoking, or what we call the passive smoking, because of contamination of the environment for those who smoke directly. So what do we do about that? And I think from the government point of view, a lot has been done in terms of even designing smoking areas and so on. So there's also cigars and pipe smoking going on, marijuana, the e-cigarettes, and even the shisha. So I know we don't have a lot of data on this, but still pointing towards high risk to the population. So this is how the lung will look for a tissue affected, especially with smoking, and it doesn't look good. So we really need to do something about that. So apart from direct smoking, you also have occupational factors that include environmental exposures from asbestos, the radon gas, even the household smoking, including pollution from the fuel products. So others, we also have a history of previous radiotherapy to maybe some of the lung lesion or the body lesions, the inflammatory lung conditions like the chronic or chronic pulmonary diseases, and even the genetic family history. And that also include the oncogenic viruses, not forgetting the HIV and the human papilloma virus. So if we look at the type of cancers, will allow me today to classify it into two. That is the small cell lung cancer and the non-small lung cancer. So if you talk about the small cell lung cancer, it normally presents at a late stage or at a metastatic stage. And at this point, tumors often grows proximally next to the ileum. And normally it involves the neuroendocrine cells. I'm going to talk about that briefly in a moment. So we also have non-small cell lung cancers, which normally forms about 85 to 90% of all the lung cancers. And if we classify these, number one, we normally look at adenocarcinoma. And adenocarcinoma normally involves the gland cells, such as the goblet cells, and grows in the peripheral lung tissue. So another non-small cell lung cancer is squamous cell carcinoma that normally grows at the proximal lung tissue that is also close to the ileum. So if you look at squamous cell carcinoma and the small cell lung cancer, you realize both of them grows proximal to the ileum. And any growth next to the ileum involves the formation of these neuroendocrine cells. So you will get that in terms of formation of these neuroendocrine cells, it becomes more in terms of small cell lung carcinoma, and also in non-cell targeting the squamous cell carcinoma. Then lastly, under non-small cell lung carcinoma, we have the large cell carcinoma, which normally grows either proximal or peripheral lung tissue. So talking about the formation of neuroendocrine cells, these cells may lead to a phenomenon which we normally call the paraneoplastic syndrome. So more common to small cell carcinoma and a bit in squamous cell carcinoma under non-small cell lung cancer. So these neuroendocrine cells will lead to production of, for example, parathyroid hormones. And if you look at this hormone, it will normally target the bones that in turn leads to breakdown of minerals, hence releasing calcium into the bloodstream. And in such patients, they normally present with hyperkalemia. Apart from parathyroid hormone, we also have ACTH-like substances produced by these neuroendocrine cells. And with the ACTH-like substances, it normally stimulates the adrenal glands, which in turn will produce the cortisol. And with cortisol in the body, then we are going to have a lot of stress and increased sympathetic activities. Then another third hormone which may be produced by the neuroendocrine cells is the ADH hormone. And the ADH, we know that it normally targets our kidneys, and as the result, it will stimulate the nephrons to reuptake the water. So we'll get a lot of fluid retention from such patients which present with the side effect that is produced by the formation of neuroendocrine cells. So that's how we simply classify the type of lung cancer. So talking about the signs and symptoms, we have several, and we will allow me to use this poster to illustrate. Normally have 10, and the number one sign and symptom is chronic cough. And you will realize the signs and symptoms will mimic almost all the features we get in pneumonic lung processes, like in tuberculosis. So a patient will present with chronic cough. There may be coughing up blood, and there is also wheezing sounds. Then we have infections, chest pain. We also have difficulty in swallowing, especially for those who are having maybe metastatic disease of the lung cancer. The hoarse voice or raspy voice, shortness of breath, and unexplained weight loss, including the nail clubbing. So anything affecting the lung, you know the pathophysiology about nail clubbing. And now that if these signs present, we may not say this is lung cancer per se, but from the clinical history, the clinical investigation, the imaging investigation, then we may come to a conclusion whether this is signs and symptoms as a result of lung cancer or so on. So as we talk about these signs and symptoms, we also need to do a lot of clinical evaluation to see whether we are narrowing down only to now the signs and symptoms pointing towards the lung cancer. Then in terms of diagnosis, as I have talked about earlier, we want to look at the clinical presentation of a patient. So if patient is coughing, as a history, is he also presenting with dyspnea or apnea, history of weight loss, the fever of unknown origin, then coupled with the history of smoking and other morbidities, then we need also to rule out whether the clinical history in terms of cough is pointing towards lung cancer. Apart from the history, another important thing is do physical exam. How is the patient presenting at that time? From cachexia, respiratory distress, effusion or lung consolidation, bone tenderness. We also have patients presenting with hepatomegaly, lymphadenopathy, and neurological deficit. So we also need to check on that. So for imaging, in terms of chest X-ray, we need to take an X-ray that is posterior, anterior, and lateral views. And in terms of chest X-ray, what do you want to look at? You want to look at the pulmonary opacity. You want to look at the hilum enlargement. You want to look at the presence of pleural effusion in case, and also presence of lung collapse. And this normally depends on how large the tumor is in the lung. So X-ray is very important. Then we also have a CT scan for the chest and abdomen, just to rule out in case of METs, very important. Then we have the PET-CT, just to check for distant disease, mediastinal involvement, And we also have brain CT scan and MRI. And we normally have several networks advocating for brain and CT or MRI. For example, all patients with the stage 1B and above, and this is according to a national comprehensive cancer network. We also have patients who are going for curative treatment. Then we really need to have a brain CT scan and MRI as recommended by ESMO. And how important is the PET or CT on staging? This one will help us to improve detection of the tumor and nodule stage. It also reduce the rate of futile surgery by early picking of the metastatic disease. And if this is available, then it in long run, then it becomes cost effective. Then these are just some of the images on CT scan and X-ray, very important for us. Then in terms of diagnosis, we also want to talk about biopsy. And if we talk about biopsy, we're talking about the removal of a sample of a tissue that will enable us to do an examination, a finer examination under a microscope, so that we can check whether there is presence of cancer cells or other abnormalities. So biopsy, we normally recommend that it be performed under imaging guidance. Then as we do that, we should also not forget about the pathology in terms of primary tumor and lymph nodes. Looking at that, looking at the resection of the specimen, then also looking at the molecular profile in terms of metastatic disease, because this is really going to help us in terms of management. We want to look at the mutations. We want to look at the ALK rearrangements. We want to look at ROS rearrangements and even the PDL expression. Then that is just a picture demonstrating on how on the process of taking a biopsy. Then another important component is staging of lung cancer. And if I'm talking about staging of lung cancer, this is very important and to be performed under a multidisciplinary team. We're going to discuss about the patient and even coming up with proper management depending on the findings which are going to be presented. So we talk about staging, we talk about TNM, and I know most of us knows about this, talking about the tumor itself, the nodular involvement, and also talking about metastasis. I know there is also 8th edition in use, and this started from 2017, 2018, and we are just going to see a summary on the same. So in terms of staging, some also look at the tumor itself in terms of size, less than 3 centimeter, more than 3 centimeter, but less than 5, then more than 5 centimeter, and tumors more than 7 centimeters can also help us to determine the stage. Talking about the 8th edition, this is how the 8th edition looks like. I know we have a number of means of coming up with the grading, but this is just to summarize on the staging of cancer of the lung. Look at the tumor in sputum, bronchoscopy, and no evidence of tumor or carcinoma in situ. Then talk about the tumor itself in terms of size, talk about involvement of the main bronchus without the carina, then also talk about the dimensions, not forgetting about the nodular and the distant metastasis. So that's the grade, the summary I want to make in terms of staging. Then treatment, I'll go in just in overview on this. So treatment for lung cancer normally depends on the stated outline, that is what is the type of cancer. Is it a small cell? Is it a non-small cell? Then what is the stage of the lung cancer? So what is the age of the patient, the performance status of that patient, presence of other medical conditions like the heart condition and so on, and in terms of patient preference, depending on the ability, what is available for that patient. So these are the things we normally advocate when we sit down as a multidisciplinary team to come up with a treatment for a patient with the lung cancer. So treatment option, we normally have number one, surgery. And if we talk of surgery is normally divided into different approaches. Number one is we have what we call the lobectomy. And in lobectomy, this is still undergoing a lot of clinical trials, but I think in advanced country, this is going on. Then lobectomy normally involves removing of the part of the lobe. So is it on the right side? Is it on the left side? So a lobe may be removed during surgery just to remove the tumor. Then we also have what we call the wedge resection. And in wedge resection, we normally remove tumor surrounded by the healthy lung margins. Then after that, we look at the margins whether the outcome is good or it needs more resection. Then apart from wedge resection, we have what we call the segmentectomy. And in segmentectomy, we normally remove more lung tissues and lymph nodes. And it is more skills requiring as opposed to the wedge resection. So the fourth procedure or approach in terms of surgery, we normally have the pneumonectomy. And in pneumonectomy, this is normally applied to those tumors which are close to the center and the high-risk ones. So in summary, those are the four approaches for surgery. Then we have radiotherapy, and in radiotherapy, we use it based on the following four goals. One is a primary treatment for the tumor, then before treatment of other treatments, especially when the tumor is large and we want the tumor to at least shrink or reduce in size before surgery, then we can also do the radiotherapy. Then we can also do radiotherapy after treatment just to work on the residual cells. Then we can also do radiotherapy as a remedy to relieve patients of symptoms. And this is normally done commonly to palliative radiology for those patients who have stage 4 and above. So still radio for palliative care can still be recommended. Then for chemotherapy, preferably for stages 2 and 3, and the goal here is to treat the tumor itself and also to ease the cancer symptoms. I'm not going to tackle the drugs per se, but just to highlight that we have chemotherapy, and most of this treatment you will realize is individualized as per the patient. Then we also have immunotherapy, and this normally involves the use of natural defenses that will help us to improve the immune system. So if we talk of the immunotherapy, I know this has been going on. And if we talk about examples on this, talk about the PDL blocker pathways. We also have CTLA pathway blockers as part of the immunotherapy agents. We also have targeted therapy, which has really made a major milestone in terms of cancer management. And as a result of this, there is more of clinical researches going on, and I think a lot of products will come out of this. And the targeted therapy normally target the proteins and the genes that play a role in cancer growth. And I think this is a promising approach, and with the clinical trials going on, I think advanced stages in terms of targeted therapy will be achieved. So talking about the general management, I know talking about cancer, any cancer is a journey that starts, that makes everyone in the family and even the individual patient to require a lot of support. So if you talk about general management, we want to look at briefly about the 5 presentations. That is, how do we care about the cancer pain? So the pain may not only be in the patient, but also the support system that that takes care of the patient in terms of finance, in terms of moving this patient to the hospital, in terms of being around the patient every time they need support. Then if we're talking about pain, we are not only looking at the patient, but it is patient and the support system. And looking about the drug effects, very common. We also have adverse drug effects to most of our clients. So how do we deal with this? It is not only reassurance, then reassurance alone, but how do we teach the patients to know about the side effect, what they need to do at home, when do they need to come to the hospital. Then another very important component is the nutritional care of this patient. This patient needs to have something at least to eat. And I know cancer may not now define which area they attack. It will attack even the population with the low economic status. So how do we make sure that even those who have low economic status are able to get something in terms of nutrition for their body cells? Then there is also a component of end-of-life care, very important. And I know from the panel we have experienced people who may also talk vastly about the end-of-life care, and that includes the last days of life. Very important in terms of lung cancer management, bearing in mind of the prognosis or the outcome of the tumor. I want to stop there, and for more references, kindly reach to these ESMO guidelines and NCCN guidelines. So thank you very much, and allow me to stop sharing.
Wow, thank you very much, Ken. That was a very elaborate presentation. And me personally, I've learned a lot from it. And so far, I've not seen, maybe there could be questions and concerns, but I think we will keep them until we finish the presentations. And thank you very much, Ken, for that. I know even the audience has learned. So at this juncture, I would like to release Ken so that Karen joins in and starts her presentation. Karen Kasera is an oncology nurse. She is based at Homa Bay Teaching and Referral Hospital. Whatever she's going to present to us covers all that is done, not only at Homa Bay, but even in various institutions. Karen is also a wound care nurse, a trained, and is doing a great job in Homa Bay. So at this juncture, I welcome Karen. Karibu, Karen, if you are in. And if possible, you can sharing your screen. So
Thank you, Pamela.
So I believe screen share is enabled. So you can share your screen and go ahead if you have your presentation ready with you. Survivor, as we still wait for Karen as she works on her presentation, so that we don't waste a lot of time. And sorry for that mishap. Sometimes things happen like that. So at this juncture, I would like to welcome Florence Nyambura. Florence is one of our lung cancer survivors. I've seen some questions on lung cancer survivorship, on survivors, and I think some of them will be addressed during the time that Florence will be talking. Welcome, Florence.
So I can do it before the survivor.
Hello. Hello.
Yes, Pamela.
Karen, someone else had already started and we wanted to give you a later chance.
Okay.
Yeah, so Florence, go ahead. When you finish, we'll give Karen the chance.
Good afternoon, everyone. My name is Florence Nyambura. I am a lung cancer survivor, but haikuanzia lungs, ilikuwa imeanzia cervical cancer, na nilikuwa diagnosed at stage 1B cervical, ikadelay, ikakuwa juu ya kukosa mahali ya kutibiwa. Wakati nilifika mahali ya kwenda kutibiwa, ikawa already imefika stage 2B. Kwa hivyo wakati wa kutibiwa, sikutolewa nyungu ya mtoto, nilienda nikafanyiwa radiotherapy na nikarudi nikatibiwa tena. Alafu ikawa wakati huo nilikuwa nimedelay, cells zilikuwa zimevuka zikaenda kwa lungs, of which sikuwa nimejua. Nikatibiwa, ile ingine ikaisha na nikaangaliwa, nikaonekana already hiyo imeisha. Lakini after some time nikarudi nikaanza kukohoa. Kukohoa ni kama mtu ako na TB. Nikakohoa, nikakunywa dawa zote zile zinafaa kunywa na mtu ule anakohoa. Na wakati nilitibiwa na zikaisha hizo dawa, nikaambiwa na daktari, sasa tumekupatia dawa zote na hujapona. But lucky enough, my sister was a nurse. Akasuggest tuende ENT clinic. Ndio nikaenda Kenyatta, nikaangaliwa, nikafanyiwa x-ray. X-ray ikaonyesha kuna kitu wakanituma kwa CT scan, nikaenda kwa CT scan, scan ikaonyesha kuna something kwa lungs. Sasa hapo ndio nikatumwa niende nikafanyiwe biopsy ya lungs, nikatolewa hiyo kitu ya kwenda kupimwa kwa lab, na wakati ilitolewa ilionekana iko na kansa. Sasa daktari akaniambia, juu already umepatikana na kansa ya lungs, ile imetoka kutoka kwa cervical, ni cells zimekuja zikapita kitambo utibiwe kwa cervical, zimekuja mpaka kwa lungs pande ya left, na sasa utaenda na ufanyiwe biopsy. Biopsy ikaonyesha niko na hiyo kansa. Kwa hivyo nikarudishwa kwa clinic, daktari akaniambia nianzie kufanyiwa chemo, na nikaambia niende nijipange, na nikarudi nikaenda nikaambiwa nitafanyiwa chemo 6 sections, of which nilikuwa naenda after some time nikafanya 6 sections, na hiyo ikakuja ikamaliza hiyo maneno. Lakini hiyo kutibiwa, nilitibiwa, lakini lungs zangu zilikuwa affected na sauti yangu ikabadilika. Hiyo sauti unanisikia naye yangu ilikuwa ya soprano, lakini ikabadilika na haijawahi change tena. Sasa nitakuwa nikienda kwa vikundi za wale watu wako na kansa, nikakuwa advised niende Nairobi Hospital, nikaadvisiwa niende huko tu, ndio napata watu wanakuambia tuende kwa Ushidi. Sasa Ushidi yenyewe ndio tumekuwa tukitembea na wao, Ushidi Cancer Survivor Support, tunaenda kutiana moyo, na mpaka saa hii nasikianga tu niko sawa. Ni vile tu unaendaga clinic, lakini niko sawa.
Asante sana kwa hiyo kwa hiyo kushuhudia kwa ajili ya maisha yako na vile umetembea na mambo ya lung cancer. Sio rahisi, lakini tunashukuru. Na hata wakati mko katika hiyo group, najua mnahimizana pamoja. Asante sana mama. Asante, naendelea tu, na kama kuna maswali nini bado unaweza kuuliza, hata unaweza kutufikia ili tuweze kusaidiana katika hiyo safari, sababu mambo ya kifua iko na vitu mingi. Na hata wakati kama huu tungependa hata kuambia wengine, ukiona hiyo kohozi inaendelea, usikae tu kifikiri pengine ni kohozi la kawaida. Unaweza enda uweze kupimwa. Ama kwako wewe binafsi unaona namna gani? Unaweza kuhimiza wenye wanasikiza. Naona tuko na karibu watu 1200 na wenye wanasikiza. Unaweza kuambia nini mama?
Mimi naweza kuambia mtu akisikia kitu azipuuze, anaenda immediately kwa hospitali, na daktari akiona unafaa kufanyiwa check up ya aina fulani atakwambia. Juu hiyo kupuuza hiyo ama kuona tu hii ni kakohozi tu, hiyo ndio ilileta hiyo shida. Na ujue kansa ni kitu very expensive kutibu. Ujue mimi kwanza nilikuwa nimetibu ya kwanza, nimeenda hiyo mambo ingine mingi na kutumia pesa. Sasa mtu akisikia kitu kidogo hivi tu asipuuze. Juu kama lungs niliona ni kitu iko na shida, unakohoa tu na unaona tu ni kahoma, lakini hiyo kahoma inakuja tu inakuletea shida zingine. Mpaka saa hii nasikianga tu sauti yangu haikurudi vile nilikuwa na yani vile nilikuwa naongea, nilikuwa naenda kwaya naiba soprano. Sasa already niliwacha juu ilinishida. Kwa
Asante
hivyo
sana.
kila mtu akisikia tu symptoms fulani akimbia kwa daktari ndio aweze kutibiwa haraka kabla haijakuwa sana.
Asante sana Florence kwa himizo hilo, na kila mtu amesikia. Unajua hata kitu kama gari tunapeleka service kila wakati, lakini saa zingine mwili tunangoja mpaka ituambie ni kuna jambo fulani. Lakini hata ukisikia kitu kidogo vile Florence anatuhimiza, uweze kuwaona daktari ili uweze kufanyiwa uchunguzi na ijulikane sio jambo lolote ambayo uko naye ama kohozi, inaweza kuwa lung cancer, lakini inafaa mtu aende apimwe. Asante sana Florence. Ningependa kuchukua nafasi huu kukushukuru na tena kukaribisha Karen ili aweze kuendelea na sehemu hiyo ambayo ilikatika. Welcome Karen. You can now go ahead. We are able to view your screen. Karibu sana. As I had told you, I'd introduced her, and I think the rest she can say as she gives the presentation. Welcome, Karen. I can see your slides moving, but I can't hear you talking.
I've introduced myself as Karen Kasera. I work at Homa Bay County Referral Hospital at the Oncology Department of Homa Bay County Referral Hospital. I'll go straight to the signs and symptoms because my colleague has covered the rest of the parts. So I'll start with where there is signs and symptoms of lung cancer. There we are. So just like my colleague has said, lung cancer is a very tricky condition because there are so many conditions which present like lung cancer. And if our clinicians or health workers are not keen on diagnosing lung cancer, then so many people will get lung cancer because it presents like any other respiratory tract infection. So let's go through the symptoms of lung cancer. We have persistent cough. This is cough, whether you give antibiotic, you treat in which way, cough will not. Go back to the other slide. There is something wrong. Hello. Yeah. Please, you are moving too fast. Can you go back to the other slide? From signs and symptoms. Yes. So the persistent cough will go for months. You treat with antibiotic and it doesn't respond. Sometimes we get these patients with the persistent cough because they cough usually blood or maybe sometimes sputum, being confused like being treated for TB. So it is a persistent cough which has a lot of problem with these patients. There is hoarseness of voice. There is persistent chest pain. Always they complain of chest pain, depending on where the problem is, if it is left or right. There is shortness of breath with wheezing, and there is also frequent of infection. So you treat pneumonia, you treat bronchitis, it doesn't get treated. And usually I said the cough can be with blood or sputum. The next slide. Next slide. Next slide. Hey. Okay, all these patients, we have seen them in the clinic. They usually have weight loss, they lose appetite, they are fatigued, there is persistent headache, and there is bone pain. And mostly for the patients who there is metastasis. So they usually complain of bone metastasis, which can also lead to fractures. Next. Next. Next slide. In lung cancer, sometimes it creates a substance similar to hormones, which Dr. was talking about, which will lead to muscle weakness. They complain of nausea, there is vomiting, they usually retain fluid retention. There is high blood pressure. When you take their blood pressure, it is always high. They develop conditions like diabetes. When you take sugar, it is high. Sometimes it reaches a time when the patient becomes confused of the high burden of the symptoms which are seen. Next. So basically, it is very, very important for us to prevent cancer, not only lung cancer, but all the cancers. There is something we can do as health workers to minimize. And mostly for lung cancer, it is very, very important that we reduce the tobacco consumption. Once the tobacco consumption, which has been found to be the cause of lung cancer, at least we will be somewhere. Our percentage of, there will be a percentage of reduction of lung cancer. It is also important to avoid carcinogens at work. We need to choose a healthy diet. That is food which is rich in vitamins, vegetables, low in sugar, and high protein. It is also very key to advise patients with lung cancer to do a little bit of exercise, which can enable them to exercise, which can also make them exercise which is low and which can also make them feel better. So we should not force them to do a vigorous exercise, but just exercise which he feels he can and he can obtain. So exercise is very key at this time when they are going through treatment. Next. So as we go through cancers, I would also like to talk about palliative, because most of these patients, they pass through palliative. And we say palliative is from diagnosis up to the end of life. So what is palliative? Palliative care is an approach that improves the quality of life of our patients. We said patients, they are not alone. They came from families. So we involve families at any given time. And we said, as we manage these patients through palliative, it gives us a better time to identify, assess, and treat, and the treatment of pain and other problems which might occur. The problems can be physical, psychological, social, or spiritual. So at that time, as you do your assessment, you will really know where these problems are. But at the beginning, we have to involve the patient, the family, and even the friends, because we see palliative, we start working from diagnosis, and it is a long journey. We prefer working with this patient from the time they get their diagnosis up to the time we can say end of life. Next. So we have our goals of care in palliative, and our goals of care include, we want to relieve pain and other symptoms. Any symptoms the patient can come with can be managed at the palliative care. And we have also, palliative care works as multidisciplinary. We have other cadres. So we manage the symptoms as they arise. We also address emotional and spiritual concerns with the patient. So we have enough time with them, with the family. They have to, we do our assessment of psychological assessment, and we know where to range the patient. It also improves quality of life of our patients and the family. Just through knowing more about the patient, so many patients has come and has approved to us that they got helped. So it is very, very important for us to involve the family at the go to improve the quality of life of this patient. And it also makes us to coordinate patients, care and referral. Not all hospitals can manage the patient as at a go. There are some hospitals like where I am, chemotherapy, radiotherapy are not there. So as we do the basic, maybe the investigation and taking of biopsy, we can refer to where other services can be offered. Next. So in palliative, people with lung cancer often experience signs and symptoms of cancer, as well as side effects of treatment. Dr. mentioned about the side effects of chemotherapy. There are so many side effects which these patients come with. And as they come, sometimes because of the side effects, some even get tired on the way and they feel like leaving. And that is where the palliative team is very keen. Once we know you have started chemo, if you fail, we have to follow you and we encourage you. And we know why you are not feeling like completing your session. So the side effects can be managed by minimizing them and ensuring that the patient is comfortable before starting, during, and after cancer treatment. There is a study which showed that patients with cancer which pass through palliative department, they live longer than the ones who get treated and they fail to pass through palliative treatment, because all the patients does not know much. But as we continue educating them, telling them about the side effect, working with them, they feel better and they feel like completing their treatment. So the patients who receive supportive care reported improvement of quality of life and they survived longer. And they come and testify where they reach end of life, but the family get happy because the life was prolonged. Next. Next. So in the palliative department, just like any other place or in a cancer department, all patients need to be assessed. Assessment that is done every time the patients come, because you might realize there's something which was not there. So you have to assess the symptoms such as shortness of breath, cough, and you take proper history from the patient and the caretaker. From here, you will know whether the patient is improving or the patient is deteriorating. The patient will also tell you whether the condition, the symptoms are becoming worse or not. You will also see the weight loss or whether the patient is gaining appetite. So usually, we refer these patients wherever necessary after assessment. You do your assessment, anything you notice, we have to refer the patient to the relevant authority. Next. Next. Let's talk a bit of the barriers to palliative care. Usually some patients, when they are sent to palliative care, they get worried. And they say they don't know much about palliative care. And they get worried why they are sent there. Because of this, we have found so many barriers. And most patients, when you go to see them, they see as if there is end of life. There is no more life in front of them. So these barriers, like lack of awareness among policymakers, health professionals, and public as a whole, is making and the public as a whole about palliative care and the benefit offers patients and relatives. So many people does not know what palliative does to this patient and the benefit the patients have when they come to palliative care. Because we talk of palliative being a holistic department where we offer physical, psychological, social, and spiritual care. This is what they get when they come to palliative care. And from there, communication, we have very good communication with our patient. We take time with them, and we really need to dig more so that we see where the problem is. There is also misconceptions about palliative care, such as that the patient only with cancers are supposed to attend the palliative care. Palliative care is for all patients who need palliative. It is not only cancer people who need to attend palliative care. So for all our patients who attend palliative care, it is important to be there to get what we're supposed to get. There is also misconception that improving cases to opioids analgesia will lead to increase of substance abuse. Usually, we have gotten a drug called morphine, which is very good for pain management. And so many people think that the patient will be addicted to morphine. And morphine, we know there is no addiction unless you are not having that severe pain. So these are the misconceptions which some people think when you start a patient on morphine, the patient is having severe pain, comes to palliative department, you give morphine, they say that is a wrong drug. So with those misconceptions, improving access is becoming difficult. Another barrier is cultural and social issues about beliefs about death and dying. People fear talking about death and dying, and therefore it is a big challenge, but we have to talk about it because we know everybody will die at a given time. So once they come, you have to prepare them. Mostly at the end of life, you have to talk about it. And it is a challenge because sometimes you talk about it and you will not see that patient again. So our cultures usually does not allow. To some cultures like maybe the Luos, when you talk to a patient about dying, somebody might think differently, but those are the challenges we have at the ground. Next. Just to add on something, it is very, very important to deal with prevention of cancer. Just like all the cancers, prevention is the key. Just the way we have talked about lung cancer, if we start having cough and we report to the clinician, and the clinician take initiative of maybe treating you and doing other investigations, in time, I think we will not reach with lung cancer at the 3rd stage or 4th stage. We'll get it at early stage, which can be managed. So all screening are good. For cervical cancer, we have the immunizations, HPV, which is being given for children from 9 to 14 years. Let's go for that. For other cancers, let's go for screening so that at least we prevent. And if maybe we get the cancer, we get it early enough where we can be managed with less resources than going to the 3rd and 4th stage, where we use all the resources we have and there is no proper management. Otherwise, thank you. Back to you, Pamela.
Wow, thank you very much. That was a very nice presentation. And even the aspect of palliative care has been covered quite well. I know our time is up, but there are a few questions that needs to be addressed and maybe others which will have to come up. I believe Ken has been answering them on answer on the chat box. But remember that whenever we come across patients who need palliative care, let us refer them to the rightful place. Some of us hold on to patients who actually need better care at the palliative center. And just as Karen is saying, culture is something which is really causes it causes a challenge. It causes an obstacle in management of these patients who need palliative care. Because sometimes you find that, like us, when we are starting up the issues of palliative care, you'd find that we as the healthcare providers, we were stigmatized because people would say that, who are these people? Wherever they go, somebody die. Wherever they go, somebody die. So palliative team were associated with death, yet we were getting these patients when it was too late. So you cancel them for a day or two, just like Karen has said, you see them once, the next time you don't see them. So we really still have to deal with cultural issues surrounding palliative care. I don't know whether Margaret is still, Florence is still online, because there is a question. Yeah, Florence, someone is asking, how long ago were you treated?
Now, I'm a cancer survivor for 10 years.
10 years?
Yeah.
Wow. So you see, if it is diagnosed and if it is managed well, people can live as long as life can allow them. That is very good. Yeah, that's very good. I don't know whether there is anything you can add. And maybe Ken, would you want to address any question live?
No, thank you, Pamela. I think I've tried to type majority of the question, but let me just see this one. Somebody asking about the blood works, how important blood work is. So I think before administration of chemo, it is better for us to do blood works, and that will include a full hemogram, liver function test, and so on, because we really want to make sure that as we administer the drug, the indicators or the indices of the patient is okay. Because if we give, for example, chemo in anemia, the outcome may not be that good. So apart from just looking at the normal indices of the patient, it is also good to do blood works just to look at mutations, especially in lung cancer, that will really advise us on what type of treatment this patient may need. For example, we want to look at the what we call the alkaline levels that normally help us in terms of cell division. We also want to look at the KRAS, that is the Keystone rat sarcoma viral oncogenic homologue. And we know how this is important in terms of controlling the growth of the tumor. And also you want to look at the epidermal growth factor receptors, what others call EGFR, that will normally help us in terms of checking at the protein that is involved in terms of cell division. So we are not only looking at the blood work in terms of having determinants on whether to start chemo or what are we going to monitor as we start chemo, but also to look at the type of mutations that will also advise us on what to do at a particular point. Then there was also a question on primary level facilities having challenges in terms of doing cancer screening, particularly for the lung. I know it may not be easy because of the structures in availability at that stage in the primary levels. But should a patient come with respiratory disease, which you think is TB, and try to diagnose TB and you're not getting the results, and I know in majority of sub-county hospitals will get the gene expert machines to help us diagnose TB or rule out the incidences of TB, then we need to refer that patient earlier and follow up. Referring alone to a facility may not be helpful if we don't follow up on that patient to see whether they reached the distant referral area and get a help at that particular time. So I know it may not be easy to diagnose lung cancer in the primary level facilities, but it is good to be having a high suspicion of index. This patient, we try to diagnose of TB and we don't get TB, then we need to refer them as early as possible. And the main thing is to do a follow-up and see whether this patient gets help. Thank you.
Thank you very much, Ken. Karen or Florence, does someone have something to add before I get back to Kenco for closure?
Hello,
Hello?
this is Florence again.
Yes.
Ningependa kuuliza Kennedy, juu tunajua kuangalia matiti ndio ujue vile iko, ama tunajua kuna cervical cancer vile tunaendaga screening. Sasa mambo na lungs, how can you go for check-up?
Yeah, thank you very much, Karen. Asante, Karen. Kuangalia cancer, huwa tunasema kuna hizi cancer tunaweza screen na kuna zingine hatuwezi screen. Ukiangalia kama matiti na saratani ya mfuko ya mama, tuna uwezo ya kufanya screening hata kwa hizi zahanati za chini vijijini, lakini tukiangalia saratani ya lung au yenye tunaita lung cancer, mara mingi hatuwezi kuwa na vitu za kufanya screening, lakini mgonjwa akiwa na hizo dalili ambazo inaonyesha labda ana TB lakini hana TB, baada ya kufanya utafiti, ndio maana tunaambiwa kwamba ukifanya utafiti na tusipate ugonjwa ya TB, ni vizuri tuendelee na kufanya utafiti zaidi ili tujue kama sio TB inaweza kuwa ugonjwa gani. Najua kwa hizo zahanati za chini ni vigumu kujua, lakini ni vizuri tutume wagonjwa wa zahanati zenye ziko na vifaa yenye inaweza kutusaidia kufanya uchunguzi zaidi. Asante.
Asante sana.
Asante sana. Kama kuna mtu yoyote ana jambo, time yetu imepita, na ningependa kuchukua nafasi kuwashukuru wote, just to appreciate each and everyone, the organizers, those who are able to attend, those who have been able to contribute, those who have been able to ask questions, and if they are answered. And we just want to say thank you, all of you. And maybe until we meet again, I want to say bye-bye, unless Kenco has any announcement. Is there any announcement from Kenco?
Yes, Pamela, ours is just to appreciate everyone who has been on board and everyone who has made this a success. To you, our moderator, Pamela, thank you so much for taking part in this. To Ken, to our warrior, Florence, we thank you so much. Kasera, thank you for the amazing presentation on palliative care. And also the KNH team, the Nairobi University, thank you so much for the avenue, and also to our official sponsors, Janssen, we thank you. We also invite you for an upcoming webinar next week on Wednesday, and as well as on Friday on lymphoma. So thank you so much for everyone who participated in the webinar.
Okay, thank you and bye-bye.
Bye-bye.
Bye-bye.